Hello, Professor Palmieri here again, giving you your next installment of your health assessment videos. This one is over respiratory assessment. I'm going to give you an orientation to your stethoscope, but we're going to do that a little bit closer to the end of the presentation. So I'm going to put this aside for the moment and unshare my screen so that you can see the power, or share my screen so you can see the PowerPoint. Forgive me, I'm doing this by myself. All right, so this is respiratory assessment. On respiratory, you're going to use two techniques. One of them is inspection. So you're going to be looking at the patient and kind of listening to what they say also. And then auscultation with your stethoscope. Some things that you would want to ask the patient about include their allergies. We always want to ask about allergies and what happens to them when they are exposed to that allergen. So does it, let's say, for example, they say, I'm allergic to sertraline, okay, which is an antidepressant. And you say to the patient, well, what happens to you when you take it? Well, I had trouble sleeping or it upset my stomach. That's not really a true allergy. It's still a reason why not to maybe give that to that patient. But in terms of a true allergy versus not a true allergy, it's not a true allergy. But I still would want to know that information because certainly if something upsets the patient in some way, I want to avoid giving them that. So still very important information. You don't have to share that with the patient that it's not a true allergy. They may perceive that as that you're minimizing how they feel about something. So that's one of those things, just kind of keep it to yourself inside your head. And you know the difference inside your head, but you don't necessarily have to share that with the patient. Other things to ask about would be known pulmonary disease. So if they already know they have asthma, they already know they have emphysema, they already know they have pulmonary fibrosis or pulmonary hypertension or something like that, anything that they already know about. Ask them about dyspnea or difficulty breathing. And not just, do you have difficulty breathing, but what are you doing when you're having it? Is that difficulty breathing while they're sitting here at rest? Or is it after I climb a flight of stairs? Is it when I get up and walk to the bathroom? Like, I want to know what are the circumstances that provoke that. Some things are certainly normal. If they're short of breath when they get on the treadmill and do a workout, that would be normal until their body adjusts to that cardiovascular load. But certainly that dyspnea is something to ask about. Along with that would be intolerance of ADLs or activity. So if they get short of breath every time they try to get up and do something, and they can't get their activities of daily living done because they're short of breath, that is definitely something that would impact their life, and we would want to take that seriously. Something called paroxysmal nocturnal dyspnea, or PND. Another PND you might see is postnasal drip. Something totally different. That's that junk that drains down the back of your throat. It makes you choke when you lay down. That's something different. But paroxysmal nocturnal dyspnea is common in patients maybe who have pulmonary disease, or if they have heart failure. Sometimes the onset of that, or them telling you, now I have to sleep sitting up, or I have to sleep in my recliner, that's a definite change and something that would mean progression in their disease process. So something definitely to know about. If there's any smoking or vaping history, those things have a toll on our lungs. Their occupation or their environment. Do they live right across the street from a chemical plant that's spewing things up into the air? Or are they a pipe fitter? Or I don't really know what a pipe fitter does, but I heard that they're at risk for a lot of things. But certainly if they have an occupation that puts them at risk for pulmonary issues. If they have traveled outside of the US or into areas that are known to have outbreaks at any point in time. And I mentioned already reactions to allergens, really important to know. What we're really looking for with allergens is, does it cause shortness of breath? We're looking for, or rashes, that would indicate a systemic or body-wide reaction to something, not just an upset stomach, or it made me feel funny or something. I want to know if it's making it difficult to breathe, or if it's creating a body-wide reaction. Some common symptoms that your patients might tell you, they might say they have a cough. And a cough can be a lot of things. It can be a productive cough. So when something comes loose, and sometimes patients will bring it up to their throat and then swallow it. Sometimes they bring it up to their throat and can spit it out. I think that takes some skill. So if they could do that, they've probably been having that productive cough for a long time, that they've learned how to get it up to a point where they can switch it over and get it so that it will come out. And that sounds really gross, but you're going to be nurses, so you got to get used to all this gross stuff. But I would want to know, is this cough a dry cough? Is it a productive cough? Is it wet? What are you doing when the cough happens? Does it happen when you lay down at night? So all those things can help us figure out what kind of a cough it is. So ask those kinds of questions. If it is productive, what does what they're bringing out look like? Is it just white or clear? Does it have a yellow tinge? Does it have blood tinge? Is it smelly? Things that you got to ask all those interesting questions that, and you find it very interesting, and the patient's like, wow, that's weird. But and once you start asking things and people find out you're a nursing student, they're going to tell you so many things that you may or may not want to know. But always take those opportunities as learning opportunities. I learn every time somebody tells me about their ailments, and try to learn as much as I can about it. Sometimes a cough can just be a dry cough. An example of one of these might be, I mentioned lisinopril in my last video with swelling of the tongue. Any of those meds that end in pril, they are common to cause dry, hacky coughs. Eventually, a lot of times that will go away after they are on it for a while, but sometimes it can be really naggy and actually cause the patient to want something different. And if it is bothering them to that extent, then they should get something different. We don't want our treatment to disrupt the patient's life so much if there is another option. Okay. Shortness of breath is another symptom. Ask questions about that. What are you doing when you become short of breath? Needing to sleep on several pillows or in the recliner at night. Chest pain. And chest pain, a lot of times people will think of heart origin, but it can be a pulmonary origin also. So any kind of chest pain anywhere in the chest. And that could even be upper back pain. Sometimes that is how chest pain presents. So things just to take every consideration when somebody's telling you something. Any color changes in the patient. So when I mention that you're looking at the patient, I want to look for those subtle color changes. Are they kind of dusky looking? Are they very bright red looking? Sometimes patients can get flushed looking and have almost a red appearance to them. And do you see those color changes near the core of the patient, or are you seeing them all the way out to the periphery? Like, am I seeing dusky feet? If you're seeing dusky feet, that tells you something about whatever is happening all the way down to the extremities far away from the heart. Okay. Another thing that gets overlooked a lot of times are mental status changes. Sometimes that's how patients will present when they have hypoxia. They may not even realize that they're not getting enough oxygen yet if it's just a little bit low. And their behavior change will be your indicator. So sometimes they might be a little bit confused, and maybe you've been working with them all shift and they've been fine, but now they seem a little bit different, can't quite put a finger on it. Maybe they'll answer questions a little bit inappropriately. And those are your cues that something's not quite right here. And definitely changes in level of consciousness. If your patient's alert and awake 1 minute and not the next, it's certainly something to hone in on and try to figure out what's going on. So in your assessment, you need to notice some things, okay? And you're going to get used to noticing these things. The first time that you have somebody get a little bit confused and restless, you may not pick up on it. It's almost like you have to have one of those and have another more experienced staff person say, see that? See how they look kind of restless? You may not put that together yet, but eventually you will. I know that happened with me when I was learning. I didn't pick up on it right away. But once it happens, you kind of have, that's one of those things you almost have to make the mistake first, and have somebody catch you, and then you realize that you missed a cue, and you're going to miss some cues. Remember, you're learning. So look at their respiratory rate and effort. I have Susie set on about 14 respirations. So she's breathing at about the same rate as you and I, probably right now. If I sped her up, you would notice it. You would be able to notice that she's breathing faster. On a live patient, they're going to be breathing faster, but they're also going to kind of look, they might be doing some postural things. You might notice that they can't finish a whole sentence. Okay, so that's another thing to kind of pay attention to. And I have that down here on the PowerPoint. If they're able to say a complete sentence without having to take a breath, they are probably okay. All right, looking at symmetrical expansion. If you look in your resources, it's going to show you putting your hands on the patient and watching your thumbs move out to the sides like this. You can assess expansion without doing that. That is the gold standard, but I can tell when somebody, and you will be able to too, you'll be able to tell if, let's say she's got a collapsed lung on this right side, you can tell that one side is inflating, but the other isn't. Not just by that, but they're going to have some symptoms to go along with it. And then as you look at them and you're listening to them with the stethoscope, you're going to notice this side doesn't seem to be expanding as well as the other. Look at the patient's posture. Are they sitting upright? Are they leaning forward? You can see these folks in the grocery store when they're pushing their cart and they're leaning on their cart like this and pushing. I hope you can see me in the little window there. What they're doing is they're trying to expand their rib cage. They don't even know they're doing it, but they can get a little bit more lung expansion that way. And so just something that you'll see, or you might see them sitting in a chair with their elbows on their knees. They're trying to do, it's like a tripod stance. Look at the shape of their chest. So the shape of, I'm going to go to Susie here for a second so you can see what I mean, and maybe it will work out. She is going to be, there she is, as wide as she is side to side like this. From front to back, she should be about half as wide, okay? If it's the same, so me from here to here is wider, about twice as wide than I am from here to here, okay? That is normal, so it's about a 2-to-1 ratio. If you have barrel chesting, it's the same. So they'll be wide this way and wide this way. And that tells you that they've had hypoxia for years and years, that the shape of their chest has actually morphed over the years from trying to get more oxygen. Okay, so the normal statement would be the chest contour is a 2-to-1 ratio, A to P, or AP to lat, sorry. And actually, let me tell you that again, that's not right. So it would be 2-to-1 lat to AP, or you can go 1-to-2 AP to lat. Just make sure that your larger number matches what was larger when you do that. Or you can say another normal statement is no barrel chest. That's a lot easier. So if you're looking for a normal statement that doesn't say normal, no barrel chest is acceptable. Who has a barrel chest that's normal, you might ask? And that would be newborns and little infants. If you have access to one, take a look at them and you'll see that they are very much barrel chested, and that's the way they're made. And that will change as they mature also. The ability to speak in complete sentences, their overall color, and then look for new or changing levels of restlessness or irritability. Those can indicate that there's some hypoxia. Okay, so this is where we're going to start auscultating the lung sounds. First, I'm going to show you a little orientation to your stethoscope. If you got one like this is a brand new double stethoscope with diaphragm, and it's supposed to have a diaphragm and a bell. They come with 2 diaphragms on them, okay? And most people don't know this. This is an adult diaphragm. This is a pediatric diaphragm. So you have to actually take this one off, and these come with a little kit full of stuff in it. So you want to open your kit, and you want to take out, whoops, I'm dropping stuff. There's 2 of these. These are your bells. This is the adult bell. This is the pediatric bell. So I'm going to take this adult bell out. Looks like this. Get it where you can see it. Okay. And then take off this pediatric diaphragm, and it just lefty-loosey unscrews. You're not going to break it. Okay. So that comes off. Just lay that to the side. And then righty-tighty your, okay, I didn't take that off all the way. So go farther than I did. It needs to come off all the way there. So you have this little hole, looks like that. Okay, lay those 2 pieces off. You'll know if you didn't do it right because it won't screw on like I just did. And then just righty-tighty that. So if you have one of these, it should look like this. When you go to peds in 2nd year, you're going to put your pediatric diaphragm back on and your pediatric bell. But for the 1st year of the program, this will get you settled. Okay. Another thing to know about your stethoscope is these earpieces, and they give you different earpieces also. So try them out. Find what works well for you. Some of them can kind of hurt your ears if you have to have them in for a little bit. It can kind of hurt your ears. So try out different ones at home and see what fits your ear canal the best. I like these really soft ones. Now, see how this comes out of the box and these are pointing directly at each other? You're going to take this like this and just bend it a little bit so that, see how now they're pointed like that? So when I put them in my ear, they're pointing right into my ear so that my ear can take in the sound. Okay. So try that. If you can't hear something, this might be the reason, and it's so easy to fix. So you can move it. It's not going to break your stethoscope. They make it movable like this so that you can adjust it to fit you. Okay. So you just put that in there and then lightly touch this because it's loud. Okay. Then when I want to use the diaphragm, I use this large side. When I want to listen with the bell, I have to turn this. I don't know if you heard that little click, but now I can hear with the bell. I'm going to turn it again. Hear that little click, and you can feel it settle into place. Okay, so that's that type of stethoscope. You might have a Littmann stethoscope or any kind of stethoscope. As long as you can hear out of it, it doesn't matter what brand you got or how much you spent on it. Just for now, just get what you need to get. But if you have a Littmann, this one comes already, there is no parts to change out, but it's made for an adult. So if you have a Littmann and you decide you're going to be a peds nurse, eventually you'll need to get yourself a peds stethoscope. You can still use this on peds. You're still going to be able to hear. So you really don't have to go buy anything new for that. Okay. But the same thing is true with this. This just turns and you can hear it click. Hear it click. And if you're not sure, just give it a light touch when it's in your ears, because you'll blow out your eardrums because you're all still young and healthy and can hear everything. All right, so that's your orientation to your stethoscope. Now you'll be able to hear everything. Okay, let's go back to our presentation. Okay, so we are going to listen to our patient on the front and on their back every time, okay? But we're gonna let the patient dictate the pace. Have you ever been at the doctor and the doctor is moving their stethoscope so fast and you're like, I don't know if I'm supposed to be taking a deep breath every time? Like, so give your patient some instructions and just tell them, I'm gonna listen to your heart and lungs now, or your lungs, for this presentation is about lungs. I'm gonna listen to your lung sounds now. I want you to take deep breaths in and out. And each time I'm gonna move my stethoscope, I'm gonna listen to you take a deep breath in and out. And you want them to take a deeper breath than if they were just sitting there. That makes it easier for you to hear the air movement. That's what we're listening for, is air movement. I need to know that the air is coming in and filling these lungs in an equal manner, okay? If it's not, you will know, and you'll probably know before you even listen, because the patient's gonna have symptoms, they're probably gonna have a low pulse oximetry, there's gonna be other clues that are gonna tell you something is not 100% with this patient, okay? All right, so let me, one of the things before I switch to the patient is let the patient dictate the pace. This is important with patients who have pulmonary issues right now, especially. Just taking deep breaths for you will tire them out, and they'll be worn out and they'll need a 2-hour break after you're done with them. So let them say, I'm going to move my stethoscope when you're ready to take a breath. Okay, so you adjust yourself to them. Okay, and be swift. So at first you're going to take a long time. That's another thing to tell the patient is, I'm new at this and it might take me a little bit longer to listen adequately. It doesn't mean anything's wrong. So just give them a little heads up so they don't get worried. Wow, she's been listening for a long time and I'm kind of getting worried that something's wrong. Okay, now I'm going to go back to the assessment part for you because I want you to see how we do this. Okay, adjust my camera. I have Susie, and she looks like she's laying back in the video farther than she really is. She looks pretty upright to me. And she can be sitting upright or laying back. I am going to expose her now. She's got her male chest on right now. She has an interchangeable chest. And I wish she had the female chest on because I could better show you how to work around breasts, but I think I can do it with this anyway. Breast tissue is glandular and fatty tissue. You're not going to hear through it as well. So when I do this, I have to kind of work around that. So we're going to pretend that she's got her breasts on right now. And I'm going to start, a good rule of thumb is to listen to 6 areas, front and back. Okay, so I want to go here. And I'm starting up here nice and high above where her breast would be. Here and here, comparing right and left. So make sure you go right and left. And then I go down a little farther, but I'm going to go in towards the inside. So I'm catching these areas inside the breasts. And then down here, I'm going to come out below the breasts. So you can look at yourself too and see where that would correspond on a live patient. And if you have family members that will let you practice on them, take every opportunity that you can. So I'm going to review that 1, 2, 3, 4, 5, down here, and 6. So I'm staying over the lung fields, which are higher than you think they are. The lungs are pretty up here. Once you get down in here, you're getting into liver and other things that are protected by the rib cage. So still up pretty high, but you want to work your way out. That way you're catching those lateral lung fields also. Okay, so listen to those, and I'm going to demo one for you. Okay, Susie, I want you to take a deep breath, deeper than you would normally. There's 1. There's 2. 3. 4, 5, 6. And I was ready to listen every time she was taking a breath in. And I have my attention focused on her breaths. So if there's any other noise in the room, somebody talking, the TV, ask nicely if you can pause that or turn it down for a moment while you listen. People usually will agree. Okay. Now I need to figure out how I'm going to listen to the back. I can do this 2 ways and have that be correct still. I can have her lean forward if she's able. If she's not able, I can turn her on her side, which is what I'm going to do now. Bear with me while I put the bed back flat. She has her call light in her reach. I'm going to take it away from her for a moment. And I'm going to just pull this back up over her chest while I don't need to keep her exposed to the world while I'm changing my workstation here. So I have her flat now. I am going to raise this bed up so that I save my own back. I'm going to watch my camera here. This will all match up here. Just bear with me for a second. Okay, I just need her at a working height for me. I'm going to drop this rail down. And then I'm going to help her turn. And some patients can turn themselves if you ask. Some will need help turning. Okay, she needs help, obviously. So, just going to see how can you turn over to your left side? And she can, just with a little help. And these mannequins are kind of heavy. Okay. So I've got her on her side. Just need to get a leg over here so she'll stay. Okay. Now I'm going to bring my camera over here so you can see where I'm listening. Pay no attention to her rear end. Okay. Let's do this. Okay. Now, in the front, I was working around breasts. In the back, I'm working around scapulae. Okay. So she's got 2 shoulder blades back here. I'm not going to hear anything over those either. So I'm going to take my stethoscope, same as I did on the front, have her take a deep breath. And I'm going to start 6 places. I'm going to start up here above and go 1, 2. And I'm going to move down and in because I'm avoiding the scapulae. 3, 4. And then I'm going to move out to catch those lateral. So then I'm going to go here. And you can't see on this camera, but down here. Okay. Let me see if I can adjust this a little bit. That's a little bit better. Okay, Susie, again, take a deep breath. And each time you breathe, I'm going to listen to the air go in and out of your lungs. Ready? When you're ready. There's 1, 2, 3. I don't have to count. I'm just doing that for you. 4. And now I'm going to come down here and get those lateral lung fields. Okay. That's it, Susie. You can relax now and breathe normally. Okay. Now I'm going to leave her in the interest of not making you watch me adjust over and over again. I'm going to go back to our presentation and show you a little bit more things that we need to cover. So as you're listening, listen for the air to go in and out. Listen to a few people at your house. Listen to yourself, even. If you have normal lung sounds, you should just hear the air go in and out. No interesting sounds. If you have somebody who has asthma in your family, see if you can get a hold of them and ask if you can listen to their lungs. Or a smoker, you might hear some different things in their lung fields. Okay. Some of the adventitious sound, that just means abnormal sounds, that you might hear and what they mean. So this is what you're listening for. We heard normal. You're going to hear a lot of normal here at school listening to each other. What you're looking for is one abnormal finding would be diminished lung sounds. So they're taking a deep breath, but it doesn't sound like it. I can barely hear the air going in and out. Okay. That would be diminished lung sounds or breath sounds. Okay. It might be because they're taking shallow breaths. It could be because they have something going on in there. This is a common finding when somebody has pneumonia or there's something that's taking up space that should have air in it. Okay. So that's a common thing. I a lot of times think of this as maybe they have pneumonia and the junk that's inside hasn't started to break up yet. It's still kind of solid. So you can't hear the air moving in and out. The next one is crackles. That means there's moisture and something flipping around in there. Okay. So when my pneumonia patient is starting to maybe get a little bit better, the junk that's caught in their lungs starts to break apart and you'll hear it moving. Okay. So that sounds like moisture. If you take a little piece of your hair and roll it next to your ear, you can't hear this. I can hear it, of course, because it's right next to my ear. But that is sort of the sound. That's about the easiest thing that you can do that will sound like fine crackles. With crackles, you have to be listening for them. So I have to listen to my patient and say, in my own head, this is somebody who could have crackles. So I need to listen carefully. Okay. Somebody who might have crackles might be your pneumonia patient. Sometimes patients with COPD, depending on what's happening right this instant inside their lungs, they might have it. Somebody who has heart failure will have some moisture in their lungs, and you'll hear that too. And we'll get more into right and left heart failure and all that later. But just know that those are kind of some examples. Somebody who has renal failure that hasn't been dialyzed, okay, they start to have a lot of fluid collection, and it will collect anywhere that it can. And the lungs is one of the places you might hear it. So you have to be listening for it. So turn down that TV, have the chatty visitor be quiet for a minute so that you can really hear. Another thing you might hear is rhonchi. Rhonchi sound like growly, snory sounds, like a it's like going to the mechanic and trying to describe the sound that your car is making. But it's a very growly, and they don't always sound the same. You can listen to somebody in the morning and go back and listen to them later, and they'll sound a little bit different. It just depends on what's happening at this moment in those lungs. But that's very much a growly noise. You may hear it as they breathe in and out, maybe only in, maybe only out. But those are things to make note of while you're listening. If you hear anything that sounds musical, like a real high-pitched kind of sound, that is a wheeze, okay? You'll hear that on patients who have asthma. You can hear it in other patients too. You might hear wheezes on pneumonia patients. You might hear wheezes on somebody who has terrible COPD. But it's kind of characteristic to hear them on patients who have asthma or somebody who's a smoker. You'll hear those, and that's just their baseline. It doesn't mean they're going to die tomorrow. It just means that they have slightly little narrow airway, smaller airways at times. And then another sound you might hear are pleural friction rubs. They can be hard to distinguish from rhonchi. It's not that big a deal if you call it rhonchi and somebody else calls it a rub. We get the idea. There's a grating sound, and that's what really matters. If it's a true pleural friction rub, it does sound like grating, and you're hearing those pleural linings kind of grinding. It's kind of like fingernails on a chalkboard a little bit. Not a big deal if you confuse one with the other. I'm happy that you discovered that there's an adventitious sound there. So as you're getting ready to listen to your patient, think about what is going on with the patient and what might you expect to hear. Another thing to consider is maybe you're taking care of your patient the day that they're being discharged from having pneumonia. And everybody's been saying they had crackles and wheezes and all these, and I don't hear anything. Well, maybe it's because they're better. So the things that we've been doing for them have helped. And maybe they're worse now than they were earlier. Trust your assessment. It's just your senses that you're using. So your senses don't lie to you. If you hear crackles, then there were crackles. So remember that you need to trust yourself. And you can compare your findings to what other nurses have put in the chart, but I don't want you to go in there thinking that that's exactly what you're going to hear. You might hear something completely different, and that is okay. So this will conclude our respiratory presentation. I hope this helps. Please ask me any questions that you might have. We have a couple of mannequins in the skills lab that have lots of different sounds, heart sounds and breath sounds that you can listen to. You can find them also on the web if you just go out and Google things like that. Some of them will want you to set up an account, which is a lot of the reason why I don't have things automatically posted that way, because they want your name and email and all this stuff. And I don't know, like I already have so many accounts for so many things that I really not keen on setting up an account just to hear lung sounds and heart sounds. You can probably find them for free without giving away your information. But anyway, I hope this helps, and I will see you soon.